Hello. Am I audible? Audible. Good. Congrats, Dr. Praveen. And take this opportunity to invite the next speaker, lady, Professor Sheila. She's from Tata Memorial Hospital. Her contributions in the field of airway management are exemplary. And if I go through the thing, I think I will intrude into a talk. She's a dynamic lady. Contributions in airway research are phenomenal. And in critical care, our fight is primarily against two things. One is oxygenation at the tissues. And second is against pain. The oxygen cascade, we need 5 millimeters at the mitochondria, but the start is from the airway. Compromised. You need a patent protected airway, more so in oncology. Pleasure to have you, ma'am, and we'll request you to kindly give your expert opinion about airway management in oncosurgeries.
The permission, if I may add something more. Besides being a dear friend, Dr. Sheila is currently the president of the Indian Society of Critical Care Medicine, and she has contributed significantly to the field of critical care medicine, and by publishing landmark articles, and she is part of the group that is publishing now surviving sepsis guidelines and many other guidelines. So I think a big round of applause for President of ICC.
I was thinking, how should I go about it? I was just thinking about, pulling out few slides from different talks, and I said, let me give you, some of you are anesthesiologists, some are physicians, some may be pulmonologists. So I thought, let me give you a little mixed perspective and maybe a broad overview, because as you know, people from cancer centers, this is a very specialized area of our work. So I won't do justice if in 20 minutes I just, talk on any particular aspect. So I'll give more of a broad overview on the subjects and probably, touch on some things that are very commonly occurring and not cover all the airway emergencies. So this is the Tata Memorial Hospital where I work. And broadly, the oncological emergencies that we face in this, in the ICU are life-threatening events when either related to the tumor or occurring as part of a complication of a treatment or something secondary to the underlying malignancy, and there may be metabolic conditions like tumor lysis syndrome and other conditions, or structural and airway management comes within that, where there's airway compromise or hematological or treatment-related causes. But the airway catastrophes really can be life-threatening complications, and these are something that we have to be aware of. And this is one area where, the saying that the eye does not see what the mind does not know is really important, because unless you know about what happens in cancer patients and what to anticipate, you won't know what kind of complications you can expect. So when you look at just airway management and you have a cancer patient, especially when you have some of the tumors within the airway, you're worried about the most important things you're worried about is actual or potential airway obstruction. You can have actual or potential airway loss. Mask ventilation can be difficult, and even difficult tracheal intubation. So don't take a patient who's come either with a primary malignancy or following some treatment, even radiation or whatever, to the ICU, say with a pneumonia, and you're monitoring this patient, because if you need to secure this airway and if the patient deteriorates, there are specific things that you have to keep in mind that you should know about, and some precautions you should take. And if you're occasionally dealing with cancer patients, that's more important, because then you should get the specialists on board early, and that will only happen if you're aware of the kind of challenges. So this is just, say, a patient who's, previous surgery, a commando surgery done, part of the mandible is removed. Now this patient comes to the ICU, say with a pneumonia. Now when I see him like this, he's absolutely stable, he's on oxygen, he's fine. But I must think in my mind that if this patient deteriorates, I will have to intubate him. And what are the challenges I'm going to face with intubation for this patient? This is going to be not only a difficult ventilation, this is going to be a difficult intubation. There are a lot of things about this patient that are going to make, and you know, the intubation itself can make it a life-threatening situation. So there are a lot of precautions that you have to take. So there are various conditions related to the airway where you can have airway obstruction, and that can be you know, oral or laryngeal tumors, or even any local tumors, could be thyroid, esophageal, or primary mediastinal tumors. So largely they are of the upper airway, or they can be of the lower airway, or of the central compartment, which I'll come to. But the most commonly that we see in the intensive care unit that comes in cancer centers are patients with mediastinal masses and mediastinal tumors that come with SVC syndrome, and these are the most challenging ones that we face, because not only do we have to stabilize them, but they have cardiorespiratory complications, and they often need urgent you know, airway control, which can be really, really challenging. So I'm going to touch mostly on that and some other conditions that we commonly see. But what's most important in all this, and coming again back to what Dr. Chawla said, is oxygenation. Oxygenation is paramount. Procedural oxygenation is very important. And now it's not just mass ventilation, we have more advanced techniques of oxygenation that can not only, you know, give you, you know, not only prolong your apnea time, prevent intubations, but they can also keep the patient very, you know, comfortable. And techniques like high flow nasal oxygen actually splint the airway. So when we have patients who come with stridor to the ICU, or they're waiting for a tracheostomy even outside the operating room, I often use high flow nasal cannula oxygen, and they start feeling much more comfortable, because it does help splint the airway open, and it keeps these patients who have, you know, laryngeal tumors quite comfortable. So it's really a good modality, not only to oxygenate, but also for this indication. When there's an impending tracheostomy, you could use high flow nasal cannula oxygen. Now most of these are anticipated difficult airway, and you need to really review your strategy. Are you going to do this patient awake, or are you going to do it asleep? And even if you do it awake, it doesn't mean that, you know, you're going to be safe, because even this technique can you know, fail. Maybe you're using awake video laryngoscopy or bronchoscopy, or you can even think of doing an upfront tracheostomy in these patients. Sometimes that may be the safest option. But what's most important to remember is to deliver oxygen throughout the procedure. This is really important. The peri-procedural oxygenation is very important, and we use a lot of high flow prior to intubation in these kind of patients. And even the bronchoscopies often we cannot do in supine position, so we all have to do them sitting up, so we are often facing the patient, and that might not be a way you're familiar with doing the bronchoscopy. Sometimes people do it from the head in. So these are some, you know, technical things regarding securing the airway that you have to be familiar with. Now radiation should be a red flag. You know, earlier when I was a resident, the entire neck used to be stained, you know, it used to be all very dark. So the moment you used to see the neck, you used to say, oh, this is a post-radiation patient. Today that's not the situation with IMRT, and nobody even looks at the history of any radiation. Radiation to the, you know, in head and neck cancer patients affects every part of the airway, you know, and I can just list that. I don't want to read it out, but you can get significant fibrosis, distortion of the you know, anatomy. There's laryngeal edema. You'll need smaller size tubes. Now if you don't know about this, you'll go ahead securing the airway without knowing that you could have very serious complications. So when you hear that a patient has received previous radiation, this is a patient who could be quite a difficult intubation, and you have to keep this in mind. And radiation should always be a red flag. Like I mentioned, you could have, especially when you have the TM joint radiation or epiglottis, even the epiglottis can be quite swollen, it can be immobile. You know, when you do a laryngoscopy, even exposing the larynx can be very difficult, and there can be also necrosis and fibrosis of the larynx, and their vocal cord edema. You know, sometimes when you look at the cords in post-RT patients, you know, the anatomy is completely distorted, and there'll be significant, you know, edema, and you'll need much smaller size tube. And when you give it to the, you know, radiation to the floor of the mouth, then the tissue also can be quite non-compliant. So you have to keep all this in mind if a patient has come to you after radiation therapy. Intraoral lesions are also very important. You know, usually, you know, not the conventional airway airway assessment that we do, but you should also have, you know, look at more specific things in airway management, not just looking at how's your mouth, open your mouth, is your mouth opening adequate, because especially when patients have intraoral lesions like tongue lesions or buccal mucosa lesion, where is the lesion? Are there any obvious fibrous bands? What is the site size, the location, and what is the extent of the lesion? This is very important. Like we have, you know, CA tongue patients who come with infections. These are immunocompromised patients. They often come with pneumonias. They are very stable. So while they're in the ICU and you're observing them, they're just on oxygen, always think in your mind that this patient might need an intubation, and how am I going to plan the airway in this patient, okay? Some of them, you just do open their mouth and you might see these kind of fibrous bands, okay, that might make, that you see in cancer patients, and you can also have trismus. So trismus is a little different from trismus that you see in trauma patients. Now these are the grades of trismus, but I won't go into that. Now it's really important that you should do a CT scan. Most of these patients have CT scans. And what we have in cancer is usually painless trismus. It could be a combination of also painful trismus, but it's really important to remember, like unlike maxillofacial trauma patients where you have a Lefort fracture or something, you anesthetize, once you induce these patients, the mouth opens completely. In these patients, some component of it is because of the submucous fibrosis. So you must always keep in mind that if the mouth opening is only one finger, even after you give analgesia and you give induce this patient, the mouth opening may not, it might be the same. So the painless trismus is something that, may be due to the submucous fibrosis, or even radiation related to the TM joint, or infiltration of the tumor, and this is unlikely to improve. So this has to be kept in mind. So don't think, unlike trauma patients, that the mouth is going to open completely and you'll be fine after you give this thing. So it's very important to evaluate the patient. Now, most important are these lesions of the tongue. Don't take them lightly, especially the extent is very important to evaluate, because they may be going up to the base tongue. Now these bleed very heavily during laryngoscopy, and they can create problems for mask ventilation and also subsequent attempts at intubation. And in addition to this, it doesn't allow the video laryngoscope or the direct laryngoscope blade to enter the vallecula. This tissue becomes quite non-compliant, especially if it's post-radiation. So these are things that you have to keep in mind, because then your plan, irrespective of the good mouth opening, should be to upfront do flexible bronchoscopy or an awake intubation using a flexible bronchoscopy. As you know, blood and secretions are the enemy of any awake technique. So you must plan this upfront and not when the patient starts bleeding, because once the patient starts bleeding, then you've really lost half the battle, and it can be very challenging. Upper airway obstruction is also something. You can have these patients who come with laryngeal tumors and striders. Now you have to take a call, am I going to intubate this patient or am I going to do an upfront tracheostomy? Now if you anticipate that mask ventilation and intubation is not considered possible, elective tracheostomy straight away. Call the surgeons and do an elective tracheostomy, and don't wait to do this thing. But most of them will have a Hopkins examination, or they'll have some imaging. It's also important to see the date of that imaging and when it was done, because this could be done 1 month back, and your patient may have presented to you now in the ICU with a pneumonia or something like that in respiratory distress much later, and the tumor may have progressed. So it's really important in oncology that you should look at when the imaging or the procedure, the direct laryngoscopy or whatever was done. And if you anticipate that in these lesions mask ventilation is possible and intubation could be considered possible, then you could go ahead and anesthetize this patient. Visualizing the vocal cords usually is not difficult, but you must have the Chevalier-Jackson scope of the surgeons, which is there available in most cancer patient areas, and be ready to do a cricothyrotomy or a tracheostomy. Now some patients come like this, so most of these patients who present to the ICU in cancer centers are patients who are either being sort of evaluated for treatment, or are undergoing treatment, or come with complications related to the treatment. So sometimes they may be just treatment naive, and they might come with these big nodes. They're looking fine, this lady, her mouth opening and everything is fine. Have a look at her scan, and when you look at the scan, you will see that there is significant tracheal compression, and there is also lateral displacement and intratracheal extension. So you don't know really what's below, behind her neck and what's there inside. So really, really important to visualize the imaging when this, that is done for these patients, because you'll need very special planning. And then again, this needs specialized airway management, because you have to be distal to the obstruction. You'll have to use smaller size tubes. So all this is really important consideration to take place. Now, whenever you have such lesions of the upper mid and tracheal obstruction, when you're assessing it, it's very important to look at whether there's any extrinsic compression. As I mentioned, imaging will tell you about this, and intrinsic compression as well. Now, a lot of times people think of doing bronchoscopy for these patients. Now, depending upon what is the extent of the lesion. Now, in the ICU, giving local anesthetic and even preparing these patients is not easy. In these patients who have these big neck nodes, they may be hypoxic, they might not be cooperative. The routine kind of elective bronchoscopy done in the operating room theatre is not going to be easy in the intensive care unit. So technically they are very challenging. In addition to that, they have very distorted anatomy, friable vascular tumors may be there, and fiber optic intubation may actually, because they're in their narrow lesions, People think, I'll do an awake intubation, I'll use a bronchoscope, but because of the narrowing of the lesion, the fiber optic intubation itself may precipitate complete airway obstruction, and that has to be taken into mind. And tumor, may also make the passage of the bronchoscope into the larynx quite difficult. So there are a lot of challenges, and a flexible bronchoscopy is often not a very good technique to use in these kind of patients. And most important to remember in any of these kind of compressive syndromes is that you could lose the airway. As you see, such a lady with these kind of nodes, a cricothyrotomy, which is rescue airway, or a tracheostomy may not be easily possible. So it's good to do an ultrasound prior, identify the cricothyroid membrane, so that if you want to do a neck rescue, you know which is the site that you have to approach. But most importantly, in these kind of situations, if you give muscle relaxant to these patients, and especially if they're long-standing thyroids, or if you have big neck nodes, then you can, have these patients can you can have complete loss of the airway, because after you give the muscle relaxant, and these patients have tracheomalacia as well, you can have complete, collapse of the trachea, and then intubation will be impossible, and any kind of rescue airway from the neck may or not be possible in a patient with such kind of nodes. So in this situation, the thing that can save your day is a rigid bronchoscope. So you must have a rigid bronchoscope in centers where you have these kind of patients with large mediastinal masses, or big nodes, in cancer centers where you will have these kind of compressive symptoms, because it's only a rigid bronchoscope. So this is what the rigid bronchoscope looks like, that we often use to salvage these kind of patients when we have complete airway obstruction. And the rigid bronchoscope is like an endotracheal tube which is made of metal, and this can stent the trachea open, and from one side you have a ventilating port with which you can ventilate these patients. So this is really a very, very important tool that we have in cancer centers when we have patients with mediastinal masses and big thyroid lesions and big compressive lesions that are really important and not part of the routine airway management armamentarium that you would see in general hospitals. Then coming to the most common of them all is the mediastinal masses. They are the ones that the patient presents to the ICU with SVC syndrome, and a lot of times they are treatment naive. They come from home, they come breathless, and they come to the ICU, and these patients cannot be made to lie supine. They have to be in sitting position, and then you have to also understand the anatomy. Where is the lesion? Look at the scan. This is really important while you're waiting to make an airway plan for these patients. And just to understand, you have the anterior mediastinum, the posterior superior mediastinum, and the middle mediastinum that is occupied by the heart and the other vascular structures. So these, I'll just go through this very quickly. These are the contents of the mediastinum. So it's really important, and you must understand that some of these tumors, they actually occur at the confluence of the superior, anterior, and the middle mediastinum, and that can make it quite complicated, and often they encasing vascular structures. So it's really important to look at the CT scan. Don't be very naive and just induce this patient and intubate this patient. So when they come to you, when they are already on oxygen, they're on high flow, you must anticipate that this patient may deteriorate, and I might need to intubate this patient. And how am I going to make a plan for this intubation? Am I going to do it awake? Am I going to do it asleep? And how am I going to do this? And it's always better to get someone with the expertise to secure the airway in these patients, because the biggest problem here is complete loss of airway, especially in these large mediastinal masses. Now these patients come to you, and when you only look at them clinically, only there's SVC syndrome. As you can see, there are large engorged veins over here. So depending upon the signs and syndromes, it can give you an idea of what is the area involved. If there's compression of the lung, trachea, bronchi, they'll have cough, they'll have dyspnea. When there's compression of the SVC, you'll have SVC syndrome, and you'll have typically this kind of, you'll have engorged veins, compression of the esophagus, dyspnea, involvement of the recurrent laryngeal nerve, then you can have hoarseness, or you can even have compression of the heart, the pulmonary artery, pericardial effusion. So these are different things that will give you postural hypotension. So there's a whole range of symptoms that these patients may present to you with, and you have to be very, very vigilant about these patients. And this is a scan showing you a patient, how you can see the SVC is compressed over here, and there are various treatments available. So while they come to you in this condition, now there are a lot of immediate bronchoscopic ablative therapies there. Earlier we used to radiate these tumors, and they used to literally shrink, and the compression used to be resolved. And most of these patients, you have to keep them in the position that they're most comfortable. You can't just make them lie supine. Even laser therapies and stenting also can be done. So a lot of role of interventional radiology and interventional the thoracic procedures can be done into, especially when there is major compression. But most importantly, when you try to anesthetize these patients, you have to remember that the respiratory decomposition that occurs during this procedure. So you have increased abdominal muscle tone and decreased inspiratory muscle tone at this time, and various effects of the supine position. I won't enumerate all this that can happen when you try to make the patient supine to try to intubate them. And also there is profound hypoxia when there is PA compression. So these are some things that you have to keep in mind. And the airway obstruction by the mediastinal masses, this can further, the compression by the masses can further precipitate the airway obstruction, and this can make positive pressure ventilation very difficult and also impossible. And remember one thing, that you have a situation where you cannot intubate this patient, you cannot ventilate, you cannot salvage this like your routine airway. You fail to intubate and you put in a supraglottic airway device. These airways cannot be salvaged. So you have to remember that in oncology your pathway also changes, and you may not be able to do that. And again, as I reiterated, the rigid bronchoscope can really save your day. At least once or twice in a year, we use a rigid bronchoscope to salvage these kind of airways. Now, it's not only the respiratory compromise, but also the hemodynamic compromise. You can have the pulmonary artery compression, or you can have, various structures compression may be precipitated, as I mentioned, in supine position. SVC syndrome may be there, and there can also be direct compression to the heart. There can be arrhythmias, low cardiac output. They can also have pericardial tamponade. So an echocardiography is also a must, not only in severe syndromes, but also routinely in all these patients who come with SVC syndrome. And there are various grades of these symptoms that you see in superior mediastinal masses. I won't go into details of that, but important to look at the CT scan. What is the level of the compression? Where is the compression? Where is the the mass? Which part of the mediastinum? And you also have 3D reconstruction that can give you a very good idea. But in general, as a principle, when you manage all these patients and you're uncertain of the airway, for example, the patient has just coming in and very tachypneic, then you must determine what is the optimal position for this patient. Okay, keep the patient in that position, because that is the one that is causing least compression. And wherever is the stenosis, try to secure the airway beyond the stenosis. A flexible bronchoscope is a good way to evaluate the entire airway and also to secure the device, the tube, because you can do it in the sitting position. And as far as possible, avoid muscle relaxants. Because this can further make the compressive symptoms worse. And if at all you need to use them, then ensure first that positive pressure ventilation is possible, and try to keep them in spontaneously breathing if you can keep these patients. Now if you give me 5 minutes, I just have to talk about post-op airway emergencies. Now those of you who are working in surgical intensive care unit, a little word of caution about those patients who come post-operatively. Now, as you know, in cancer, you're always trying to, you have to remove the tumor and you have to clear the margins. And when you try to clear the margins, there'll be wide portions that you have to excise, and this often requires reconstruction. And there can be significant, the flaps can be there, and this can cause significant compromise of the airway post-operatively. The patients may not be able to maintain the airway. So the strategies that are used often in these patients, intraoperatively, nasal tubes are passed, and either a tracheostomy is done electively, especially when the tumors are crossing the midline. Then you may need to do a tracheostomy when they're very vast, wide resection has been done, or they're very bulky flaps. Then that may be the kind of dictum. But there's another strategy where you can keep the nasal tube in, that was used for surgery, and the patient is kept with the nasal tube, and then probably the next day in the ICU the patient is extubated. So these are the two kind of strategies. And so there are two: tracheostomy, either an upfront tracheostomy or overnight intubation. We know about the complications and problems related to tracheostomy. With overnight intubation and extubation the following morning, there's earlier return of speech, feeding, and also less complications, long-term complications related to tracheostomy. But there wasn't really much objective criteria as to how to decide whether to do a tracheostomy or to do keep the endotracheal tube in for these patients post-operatively. And delayed extubation has the benefits because it maintains the patient airway, and you have the tube in, so if there's any rebleed or any problem when the patient is in the ICU, you don't, resecuring the airway is very challenging. So you can take this patient back to the operating room and you already have a tube in place. And also, we don't want to extubate these patients at night because of the limited staffing and problems in case you don't have the expertise for a reintubation. But of course, delayed extubation cannot be performed in all patients because some patients, when there's very wide resection, you will need a tracheostomy for this patient, because this patient will not be able to maintain the airway post extubation. So we really don't have much of an objective criteria. So at the Tata Memorial Hospital, we undertook this very big study that we published in Oral Oncology, and as to how to identify a patient, whether we should do a delayed extubation for this patient or we should do a tracheostomy for this patient. And just to tell you very briefly, this was almost close to 800 patients, and it wasn't a randomized controlled trial, but we looked over a 1-year period, and we looked at all the patients who the surgeons had either did a tracheostomy or kept them for an overnight intubation, and we tried to look at what were the complications that occur post extubation and how many had a safe airway. That means following extubation they were able to maintain airway patency and did not require post intubation. And for those patients who had a safe extubation, a safe delayed extubation, we did a multivariate analysis and we looked at what were the factors that were associated with safe extubation, and based on that we were able to develop an algorithm as to which of the cancer patient surgeries can go ahead with, what are the criteria that you can use to decide that this patient can definitely undergo a safe extubation. As I mentioned, it wasn't a randomized controlled trial. There'll be a lot of patients who could have undergone a delayed extubation who the patient surgeon did tracheostomy in, but of course we won't be able to know because the tracheostomy was already done. But it's better to have a few more tracheostomies than to have failures following extubation where the patient cannot maintain the delayed airway. So these are the criteria. No neck, if you have a patient with major cancer surgery, no neck dissection or a tumor staging 1 or 2, or no pre-op radiation, or absence of extensive surgical resection as defined by these criteria, or if it's just a primary closure or a faciocutaneous flap, these patients can safely undergo a delayed extubation rather than have a tracheostomy done, because in many centers an elective tracheostomy is done. It's quite invasive, and more of the centers now they are doing a delayed extubation. But just a word of caution, these patients will come to the ICU with a nasal tube in place, and it's not possible to keep all of them on ventilator. The tube is only there for airway patency, right? It's not, the patient doesn't need mechanical ventilation. So very important, when you keep a tube like this without the patient being ventilated, you need to counsel the patient, give a good sedation, also have continuous capnography so you're sure there's no airway obstruction, and suction only as and when required, and you should allow the patient to communicate. And when these patients are extubated in the ICU, this is very important. Most important to remember is the extubation is always elective, unlike intubation. So never be in a rush to extubate this patient. If you have any doubt that after pulling out the tube, the re-intubation may be difficult, then you call the surgeons or you call for people with expertise to do it. And an advisable thing, if it's a borderline case, is to do it over a tube exchanger, or you can even use a bronchoscope to do this. And if it fails, of course, you should have the surgeon on board and consider doing a tracheostomy. And the last one I want to talk to you about is the postthyroidectomy neck hematomas. Now these are very important. Many patients come post-op, just a simple come to the ICU just for observation, but you should be very vigilant about these post-thyroid, the neck hematomas. Now these are really dangerous because the hematoma goes on expanding, and there is the sutures are there, and after some time the patient starts getting dyspnea. You have compressive symptoms. These are very commonly occurring in cancer centers especially, or even in non-cancer centers which are large volume thyroid, where thyroid surgeries are done. And there's a very nice guideline that the Difficult Airway Society has come up with for the management of hematomas following thyroid surgery. I won't go into details about that, but they've given some very nice mnemonics as to what to watch, because these patients can have significant dyspnea, stridor, can even have hypoxia, arrest, hemodynamic consequences. So you have to be really careful, and you have to closely monitor that. They have a mnemonic called DSAT. They'll have symptoms like difficulty in swallowing, and you can use the Muse or Muse scoring system to look at them. Any swelling, anxiety, tachypnea, difficulty in breathing, stridor, they should be watched for this, and of course the neck swelling. And they have an algorithm. I won't go into that, but if the compressive symptoms are increasing, the first thing is to have the surgeon on board, but you may need to release immediately the sutures. And there's another mnemonic that they have for it called SCOOP, which is how to do how to do this evacuation. You expose the skin, you cut the sutures, you open the skin, you open the muscles, and then you pack the wound. Now it's not advisable if it's an arterial bleeder, because it can be catastrophic if it's an artery, But if it's not an arterial breather, this kind of intervention can be life-saving. Now, other than these kind of situations where you have the middle, central compartment, there are also lower down you can have various tumors causing obstruction, and that's why it's very important when a patient with cancer, say a lung cancer patient or a patient with any carinal or tracheal tumors comes to you to look at the CT scan. Our bronchoscopic evaluation is very important because it gives you a good dynamic assessment. Now, beyond tumor, besides tumors, there are also other conditions, like you can have very large pericardial effusions, and these are malignant effusions. They just well up, you drain them and then they fill up again. And like this is a patient which we had with bilateral pleural effusion, and this patient, as you see, also had a large pericardial effusion and actually just arrested in a matter of time, but had to be quickly, we had to sort of drain these effusions. And you can see this ECG of this patient, the pulses ultrasons that was taken. So my take-home message is that most of these conditions are either caused by the primary cancer or the secondary metastasis, and the upper and lower airways, they have very little room for error. So you have to be very vigilant, and very important is to understand the anatomical and physiological changes that are occurring, and this is very important to manage these. So this needs some level of expertise. You can't just say, oh, it's just a regular airway, because the airway catastrophes that occur in cancer patients are usually quite fatal and can result in significant morbidity and mortality. So that's really important to understand. And the central airway obstruction requires very urgent and very advanced kind of airway management. I didn't touch upon bleeding, but you can have life-threatening epistaxis, you can also have pulmonary hemorrhages, but this of course needs specialized management. Surgical intervention, interventional pulmonology, interventional radiology interventions are required, but the most important thing to do is intubate these patients and secure the airway. And one must also be cognizant, as I showed you that case, of large pleural effusions of varying origins, and also pneumothoraces that can contribute to a whole spectrum of emergencies which I haven't covered. And with that, I thank you very much for your attention.
Thank you very much, Dr. Sheela, for an excellent overview on the subject. And if there are any questions, you can ask her now. Any questions from the audience? Okay, I have one question. So, because the only tool that is available to us for airway evaluation besides the other clinical thing is the ultrasound. So, is it a routine that all these difficult cases your resident would have done and told you that these are the ultrasonic findings? Is it now routine in the difficult airway management?
Well, anyone coming in respiratory distress, we anyway do a lung ultrasound. But if we have a difficult airway, definitely the neck ultrasound would be reviewed, looked at for visualizing the cricothyroid membrane, as we would do for a percutaneous tracheostomy. We look at the neck anatomy, definitely, so that if you need to rescue the airway, we know exactly where it is. And it's more important in these patients who have nodes or who have post-radiation or those kind of situations where we anticipate that access to the cricothyroid access is going to be difficult. So that would be routine, yes.
Thank you.
So as Dr. Sheela said, airway emergencies are a challenge. But when it comes down to extubation, it's a strategy. So be very careful. Devise a strategy how to extubate, because otherwise you will create a challenge for yourself. And VIP, it's like a VIP route. It ought to be patent, it ought to be protected. Otherwise life is in threat. So that is the carry-home message. And practice. We ought to train our residents. We ought to be skilled enough. Because unless we are skilled, we cannot start off with a difficult airway without knowing how to do it. So the Airway Society is already conducting various workshops. We should also try to do that in our institutions, so that our residents, anesthetists, critical care experts, they are well trained. And I am sure Dr. Praveen will be continue with such workshop also in future. Thank you, madam.
Thank you very much.
Thank you.
May I now request, thank you ma'am, may I now request our chairpersons to kindly felicitate Dr. Sheela ma'am. May I now request Director Operations and Medical Superintendent Dr. Pinky Yadav to kindly felicitate Dr. Rajiv Chawla. Would request Dr. Praveen Kaur to kindly felicitate Dr. Rajesh Pandey.